I have the real pleasure of introducing our next keynote speaker, Dr. Emily Haigh. Emily joined the University of Maine in the Department of Psychology about 3 years ago, and ever since then has become a loyal member and an active participant in the Aging Research Initiative that spans the campus and in fact spans the University of Maine system. Emily has a very impressive background. She came to us after receiving her doctorate in adult clinical psychology from Kent State University. And after that, she received postdoctoral training at a very special place, the Aaron Beck Psychopathology Research Center in the Department of Psychiatry at the University of Pennsylvania. For those who know, Aaron Beck is one of the pioneers, considered the father of cognitive therapy, and Emily was able to work with him directly. She's now going to be publishing with him. He's a gentleman who's made enormous differences in our understanding of psychotherapeutic approaches in working with adults. Emily also directs on campus the Mood Disorders Lab, and there very much is focused on looking at biological and cognitive processes and how they impact on depression and other behavioral disturbances in older adults. She teaches on topics in psychopathology. Her research very much is focused on cognitive and biological influences and factors that impact depression. And more recently, I think I can say she is focusing in particular on depression in older adults in small towns and rural communities. And in particular, looking at ways in which technology can be a useful adjunctive methodology or approach to intervention, to assessment, and to more effectively reaching older adults in need in rural Maine and elsewhere. You can be sure we're delighted she joined the University of Maine 3 years ago, and I'm equally delighted in thinking that she's now, after today, going to be a member of the Maine Geriatrics family. Emily, welcome.
Thank you, Len. That's a very generous introduction. It's a real pleasure to be here today. I'm really grateful to have the opportunity to speak with you about my line of research. And as Len pointed out, it's only more recently since moving to Maine that I've worked to develop some expertise in understanding and treating depression among older adults. So I hope today to be able to provide a really nice broad overview of depression in community-dwelling older adults. Specifically, I hope that we'll be able to discuss some of the common myths and misconceptions about depression in older adults, and that you'll leave here being able to recognize, or maybe just have an ear open about some symptoms that are common to individuals in later adulthood with depression. We'll also go through some just basic kind of facts and statistics and talk about the course and the impact of depression in older adulthood. And then finally, we'll wrap up with a discussion on some of the current evidence-based treatments and what are the challenges and opportunities with these treatments that we have available. In the workshop that I'll be leading this afternoon, we'll go into much more detail about these assessment and intervention opportunities. So just to make sure that we're all on the same page, I'd like us to kind of look at the DSM-5, or the Diagnostic and Statistical Manual. As many of you know, this is the Bible for mental health professionals. It lists all of the criteria for various disorders. Here we have the DSM-5 criteria for a major depressive disorder. You'll see that for the top two symptoms, depressed mood and anhedonia, either one or both, and/or both, is required for a diagnosis of depression. So depression we start to think about this as a diagnosis if all of these symptoms are present most of the day, nearly every day, for at least a 2-week period. One thing that's pretty interesting about this set of criteria is that technically 2 different people can meet criteria for depression and only share one symptom, either that depressed mood or anhedonia. So what that tells us is there's a great deal of heterogeneity in this disorder. So it looks very different across people. And this is particular importance when we're trying to identify depression in older adults. So this very busy slide here is really the take-home message from this slide is just to give you a sense of how many different pathways there are to depression. Researchers build whole careers on little aspects of some biological factor that may be related to or increased vulnerability to depression. So generally, we think of depression as having biopsychosocial causes. Likely, all of these factors interact at some level, and it's really going to be quite a feat. I don't think we ever actually will pinpoint this causes depression. It's likely there are different causes for different people in different circumstances. So one of the common questions that the research literature certainly has been grappling with is whether depression presents differently in older adults than at younger ages. And traditionally the research literature uses the age of 65 to differentiate older from younger adults, but obviously there's no set point at which an individual becomes older. So assessment, keep in mind assessment's going to be based on, and should be tailored based on individual need. But there has been a relatively recent meta-analysis, so it gathered all of the published literature, and results of this show that there may be, in fact, a different phenomenology for depression among older adults. And this might not be surprising to some, but it seems older adults tend to demonstrate more agitation, more general somatic and gastrointestinal complaints, and more hypochondriasis or health anxiety, concerns about health. They report less guilt and less lack of sexual interest than the younger cohorts. Now, there could be there are a number of possible explanations for this. It could be that that depression in older adulthood really is associated with this different clinical picture, or it could be that the tendency of a cohort effect. So perhaps older adults are more comfortable expressing distress about somatic symptoms rather than disclosing mental health complaints or concerns. Alternatively, it might be the case that older adults, certain pathways that lead to depression in older adults, say vascular depression, may be associated with certain symptoms, more somatic symptoms, more fatigue. More research is needed at this point. So, this is a question I'd all like you to just answer quietly to yourself. I hate when you're at a presentation and they ask you to raise your hand and then they tell you you're all wrong and you're sitting there like, oh. So just to yourself answer, do you think depression is more common in late life than at younger ages? And at one hand, it's certainly, I think, the message we receive. Certainly popular and lay magazines and publications kind of paint a gloomy picture. Certainly highlighting the unique challenges associated with aging. We know that there are aging is associated with changes in residency, with changes in job status or your role, changes in relationships, changes, loss associated with relationships. And it may be that these sort of multiple challenges or stressors are cumulative and predispose people to, in older adulthood, to depression, making them more vulnerable. Well, I've got good news. Contrary to popular wisdom, late life depression is actually less common than in younger adults. So despite this exposure to these unique challenges of aging, older adults are showing great resiliency, which is terrific. And it may be that older adults find a way to use these challenges as unique possibilities for reconciliation or healing or growth or a way to cultivate deeper wisdom. The vast majority of older adults maintain positive emotions. In fact, their ability to effectively kind of regulate their emotions improves with age. And we see that the majority of older adults express enjoyment and life satisfaction. So that's great news, and I think that's the norm, and this is what we want to keep in mind, particularly when we're encountering somebody who's not fitting that norm. So let's look at the actual numbers. What are we dealing with here? We've got about 3 to 4.5% of older adults, given any 12-month prevalence period, will have a diagnosis, carry a diagnosis of a major depressive episode. To give you a comparison, the rate for anyone over 12 in that same 12-month period is 7%. So we're seeing significantly less depression. Good. The bad news is that we see that this percentage of older adults experiencing clinically significant symptoms is pretty significant, this 8 to 16% range. We also see that depression seems to be increasing, and in fact doubling in some of our older adults. And I should note that there are subgroups of older adults that do have higher prevalence rates of depression beyond this 3 to 4%. If you look at some long-term care facilities, not all, some groups in medical inpatients, but this is just a general kind of public sample is about 3 to 4%. Okay. So is depression in older adulthood associated with a worsened course? And it seems to be so. So just as like anything, it seems like it's, getting sick when you're younger versus getting a cold when you're older, it seems to have much more of an impact. So research has shown us that depression in older adults is chronic and it's relapsing. About 1/3, one long-term longitudinal study found that about 1/3 of older adults with a history of depression relapsed. Another really nice 6-year follow-up where they included anybody with current symptoms, not necessarily a full-blown diagnosis, but just symptoms. They tracked their course over that 6 years and found that 23% remitted, those symptoms went away. Little less than 4 had this really fluctuating an unfavorable course, and over 1/3 had quite a severe chronic course. So we know that, and I'll get into this a little bit later, we know that older adults seem to remit at the same rate as younger adults, but they relapse at a higher rate. So it becomes a very chronic condition, particularly if it's untreated. Part of this sort of looking at the course and the impact of depression is looking at some of these pretty sobering research results related to kind of the outcome of depression in older adults. So late life depression is associated with really some significant negative consequences. It's really showing us how important a public health problem this is. We see increased morbidity and mortality, greater risk of hospitalization and death. The suicide number is particularly alarming. So the group at highest risk for suicide are older adults. They're more likely to be successful at completing suicide. I think they usually give these rates in number per 100,000, and the rate for older adults is 19 per 100,000 commit suicide. And for younger adults, 18 to 25, the ones you think are, so tormented, it's like 12 per 100,000. So it's a significant difference. This other relationship between depression and dementia is also particularly worrisome. There was a very long longitudinal study. It was 17 years, a follow-up study, and they found that individuals with a history of depression had a 70% increased risk of developing dementia. And what was interesting about this is that it didn't matter if your depression occurred earlier in your life as a younger adult or was a new onset, whether it happened when you were an older adult. So you just were at this increased risk regardless. So if that doesn't get policymakers and grant funding people excited, this number should. It's not only, depression's not only associated with this emotional suffering for the individual, but in general, older adults with depression incur higher healthcare costs. Specifically, total healthcare costs for depressed older adults are approximately 50% higher than for non-depressed older adults. It's a big, big increase. This is particularly salient given the estimates that the epidemiologists tell us that the number of older adults living with a mental health problem, and depression is the most common mental health problem older adults experience, will double by 2030. So what can we do? One of the first steps, if we're trying to problem solve, is to identify adults who might be at risk or experiencing clinically significant depression or depressive symptoms. And as you can imagine, this is not an easy task. I've alluded to it. We likely have some sort of cohort effect where it seems that older adults are more stoic or less comfortable sharing personal emotional assessments with providers. There is a study that shows that older adults are less likely to recognize symptoms of depression, and along with their healthcare providers, they often attribute the symptoms of depression to normal aging or to a physical illness, rather than an objective entity in its own right that deserves treatment. The other issue I alluded to was this idea that depression presents differently in different folks. So it's hard to identify, and it can be incredibly difficult to tease apart somatic symptoms associated with depression and somatic symptoms that are related to an underlying medical condition or a neurodegenerative condition. So ideally, if we had all the resources in the world, we'd conduct a clinical interview, we'd have some opportunity to maybe observe a patient's behavior, we'd collect some collateral information from family and other caregivers, we'd do a medical workup and rule out other possible conditions that might be exacerbating or contributing to the patient's sort of presentation. It's generally not a luxury many of us have. Those services and resources aren't necessarily available. So for some providers, the use of rating scales may be a useful way to screen for depression. And there are many rating scales to assess depression. Fewer validated in older people. So I've put up a few examples here, if you're interested, of rating scales that I believe, I know at least the geriatric depression scale and the patient health questionnaire are publicly available, they're free, you can download them on the internet. The geriatric depression scale is not particularly useful for any older adult with any type of cognitive or executive dysfunction. That's when you might want to think about the Cornell scale for depression, which has been normed in populations that are having executive dysfunction. The patient health questionnaire maps on nicely with the DSM, and this one has a nice little iPhone app with it as well, and there's an online training available that if you type PHQ in, that you may be wondering, how am I even going to broach this with the person that I encounter, the group of older adults I encounter. And there's a nice online training with videos, vignettes, and role plays that give you an idea for how you might just start this conversation. Finally, the hospital anxiety and depression scale, its goal was to help us differentiate those somatic symptoms that might be due to a medical condition versus depression. So this was normed in older adults in a medical setting, in a hospital setting. So these are some of the questionnaires on the geriatric depression scale. I picked this because it's the most commonly used, well-validated scale. Older adults are asked to answer just simply yes or no to each of these questions. As I mentioned, there's an iPhone app for this if you want to get fancy. The way it's scored is if an individual scores a yes to 5 or more, that's supposed to suggest that a provider may want to follow up or provide a more comprehensive assessment or make a referral. So it's very simple to administer and to score. So is depression in late life more difficult to treat? Certainly, clinical work with older adults involves a complex, interacting set of factors. We have these developmental challenges that occur. We have these different cohort perspectives or beliefs about mental health, about how families should work together to provide support, about just general perceptions on depression. We have these mentioned comorbid physical illnesses and the effect for polypharmacy. We may have cognitive impairments in play. And just given that somebody's an older adult, by virtue of being older, they have probably a longer medical history. But these are all challenges, and they, thankfully, we've found that the treatment for depression is very effective. It's reversible with prompt recognition and appropriate treatment. We can prevent that relapse that we talked about earlier. And this is important, this point that it's effective, because increasing expectations about recovery really influences the outcome. So we all know about the placebo effect. You take the little sugar pill and you start feeling better. Well, the same works for a lot of our interventions, whether they're medication or they're psychological. If we believe it's going to work, that really improves our outcomes. So how is depression in late life managed? In subsyndronal or more mild cases of depression, or where you're just seeing a few of those symptoms present, some more psychosocial interventions may be sufficient. They may be enough to elicit an improvement and a shift in mood, a shift in affect. And these include adding social contact and structure to the day. Obviously, if we're in communities where there are rich resources attached to our community centers, you may have befriending programs. These are great opportunities. Often communities don't have access to these resources, and it may require more creative planning, like a weekly meetup at Dunkin' Donuts on Tuesdays. We also know that exercise is one of the most powerful antidepressants, and this is for any age group, really. I think there was just a study in the New York Times today that came out that was showing, I think yoga was found to lead to cognitive improvement in older adults. So there's certainly a lot of support behind these approaches. What about your individual who's not getting out of the home? You might consider bibliotherapy, providing a book. It's low cost, it can be self-paced, and it just may provide the psychoeducation that, hey, how I'm feeling is not really normal. You know, maybe this is actually a thing. It's not just, oh, I'm getting older, and so I should be losing interest in things. And then as providers who interact with older adults, we can promote self-care when we see areas of neglect, when we see an older adult indicating that they're having trouble with their appetite, they've lost it, they've, kind of can't find anything pleasurable to do anymore. Maybe they've had a change in their medical health status. Maybe their sleep is disturbed. So these are points where we can make an effort to convey that this should be a priority, that promoting self-care is a very important part of mental health and well-being. The other piece I'd want to raise is this idea of technology. Len mentioned that I submitted a grant where I was proposing to deliver an intervention for older adults through a tablet, like an iPad. And one of the reviewers wrote back and he scoffed and he said, oh, I'd hate to see my mother and aunt using an iPad. I was really quite taken aback by that. And I thought of my own father. He's 77. He has cognitive impairment left over from an old traumatic brain injury and probably setting him up for early dementia. He has extensive cardiovascular problems, prostate cancer, history of depression, and he's sending me selfies, every other day. So, obviously I couldn't reply to the reviewer with that. So I looked up the data and I said, okay, well, let's see what's happening. In 2015, 59% of older adults use the internet. This is an increase from 14% in 2000. Another survey found that older adults, among them, 30% own a smartphone, 32% own a tablet, and 55% own a desktop or tablet computer, an iPad. And finally, I knew they were going to come back at me with this, with broadband, right, and internet connection. So I looked this up. 40% of rural dwelling older adults have a broadband connection. And my thought was, just because maybe it's not 80%, doesn't mean in 10 years it's, it's going to stop. I mean, the internet's not going away, and all of us are going to be older adults, and we all know how to use the internet, so that's my gripe. So in terms of what do we do if we see an older adult that seems to have more moderate to severe? So they're, little pleasure during the day, perhaps they're sleeping more or sleeping significantly less, they're losing weight, they seem confused, they're agitated, kind of thinking, like, what's the point, kind of getting hopeless. That's when we might want to think about a more formal, structured intervention. And these are a few that have been empirically supported, particularly with older adults. And in the workshop session this afternoon, I'll go through and kind of briefly describe these different treatments and answer any questions. This is kind of my wheelhouse, specifically the CBT. So results from a recent meta-analysis found that all of these treatments listed up here are equally effective in older and younger adults. What you recommend and what actually gets delivered is obviously going to depend on access. Do you have an IPT therapist in your community? Does your older adult have coverage for that? Can they get to that appointment? So then you might be thinking, okay, medication, and people have preferences. Some individuals are okay with medications, some would prefer not to take medications. Medications in older adults, we've heard already about issues with polypharmacy. We might have to have more monitoring to maximize the response and to minimize side effects. There's also some data to suggest that medication doesn't work with older adults who have lower SES, socioeconomic status. So we need to, there's going to be a number of factors. Some you'll have no choice over, and some you will. So this is the good news, though. We have treatments, they work. This is the bad news. We have treatments, they work, and nobody's getting them. So adults with a mental health or substance use disorder receiving any type of treatment. So maybe you just briefly go to your PCP and mention, maybe I'd like to start Prozac. That would be any treatment, 10%. Older adults receiving specialty mental health services, 1%. So despite the availability of these great evidence-based treatments, we're not getting them out of those clinical trials at those fancy research schools and into the community. That's a really big problem. So what are the barriers to addressing depression in older adults? We can think that there's probably a number of different levels going on here. At the client level, it might be related to stigma. I don't think stigma accounts for 99% of people not pursuing treatment. But we do see some older adults really not buying into the notion of mental illness, thinking, I'm not weak, I'm not crazy. Or it could be a lack of knowledge, saying, this is what happens when you get diabetes, or this is what happens after you have a stent put in or a pacemaker. You get depressed. This is just part of that. There could be, and there are, barriers at the provider level. So obviously our primary care physicians and our nurse practitioners, our social workers, everybody's wearing so many hats these days, and there are so many competing demands. And even if you're kind of identifying somebody as being who would benefit from treatment, where are the mental health providers? That have the particular training. Even myself, this is something I'm considering myself sort of re-specializing in. At the system level, I mentioned this before, but how do we get these folks to the mental health professional? So if we've found this great psychologist who's going to do CBT, they're probably in Portland, or what if they live up in the county? How are they going to get there? How are they going to finance, in a lot of cases, this type of therapy or treatment? So we see that there are a number of very important barriers that we desperately need to address in order to, improve this dissemination of treatments for older adults. So what can we do? And really, I don't have any, I wish I did, I don't have any specific answers beyond sort of contemplating that as leaders here, what can we, how can we, sort of reflecting on our own setting and thinking about ways that we might integrate care, identifying sort of partners, who do you commonly work with, figuring out what's a reasonable strategy to maybe put in some screening, to at least provide some psychoeducation about depression. So it's sort of trying to figure out how to work smarter, not harder. And as individual practitioners, you're all doing it. You're all here, dedicated to learning new skills and new information and being able to bring those back to the older adults that you serve. So this idea that it's on our mind, we can support efforts to prevent depression in older adults and encourage caregivers to help facilitate maybe some of those psychosocial interventions like structured exercise and activity. Just generally kind of help raise awareness about the potential for depression and its really significant negative impact. So we've talked today, I've walked you through some pretty common myths and misconceptions among older adults, in particular this idea that maybe it's more prevalent and it doesn't appear to be so. But it is, however, associated with very significant impairment. And we've discussed sort of some strategies for how you might recognize an individual who has depression and how it might be difficult because you're teasing out some of these symptoms that might be associated with a comorbid medical condition. We've also talked about some of the evidence-based treatments here and how they're really exciting, but there are significant challenges to disseminating these to older adults. And I've included in this, in your PowerPoint slides, some resources particular to mental health issues in older adulthood that you may find useful. And I'd be happy to answer any questions or hear any comments that you may have.
Questions, comments? Emily, thank you. That was great. And Emily has a workshop this afternoon. Mm-hmm. And as you all know, mental health is a real issue that we don't address as fully as we should. So really appreciate your being here. Questions for Emily? I'll beat you.
Can you speak to the notion that depression often in older adults, at least I've read this, doesn't necessarily manifest in sadness, which is what so many of us in families would look to for as an indicator?
Yeah, I think that is, I think you're quite accurate in your reading. We don't see that typical forlorn presentation where somebody's mood is low. We see more irritability, more agitation, and like as I mentioned, more of a preoccupation with somatic functioning. And I think that this is, it's interesting. We're not sure where that shift is happening, and I would be curious to see whether that's something that changes as we've become more, increase our mental health literacy, whether it becomes more expressed, or if it really is not a cardinal symptom at that age, that it's, that for some reason the way an individual experiences depressions in older adulthood isn't characterized by that intense sadness. So it's a very challenging point, this idea of how do you actually recognize it when it's not fitting this classic presentation that we associate with depression. Yeah.
Emily, we're over here.
I wonder, are there differences between men and women in the symptomology or the management of depression?
That is that's an excellent question. I have not come across any studies to date that have broken it down, and that's a terrific thought because we see difference in prevalence rates throughout the lifespan. So typically, women are more likely to be depressed than men. But I don't know how that maps onto, and there very well might be some research on that, but I'm not sure how that would map onto physical symptom or the expression of these physical symptoms in older adulthood. Great point.
I was wondering if, going back to the presentation, if it might be generational in that the current generation of older adults has a cultural or social taboo for expression of sadness and deep emotion, so it's much easier to present with a somatic complaint. And if we'll see a shift in that as the boomers age, and if there's any sort of cross-cultural studies with other cultures that are able to express emotion more freely than this particular generation of olders.
That's great comments. I know we see cross-cultural differences in the expression of depression. In a lot of Asian cultures, you see these somatic expressions rather than the typical comments on mood, low mood. So you see that cross-culturally. I agree very much with you. I will be very curious to see with the baby boomers aging whether, like I said, there is this greater willingness to disclose and to discuss, the problems with loss of interest. I also think about regional issues. It's funny, since moving to Maine, and this is a generalization, but the older adults here, they're independent, they're strong, they're resourceful, they're very stoic, and I mean, again, a very big generalization, but I mean, that was something that struck me moving to Maine versus, I'm originally from Toronto, and the things I see older adults doing here, in Toronto, they might break a nail or something. So yeah, I think that it'll be interesting to see, kind of tracking this. My hope is that I don't know, that we do see if older adults are actually feeling depressed, that we do obviously see increases in self-reports of that. But it may be that symptom just isn't as prevalent at older age. Mm-hmm. Hi there.
Hi. You said that people who experience depression before the age of 65 have a 70% chance of developing dementia, right?
Increased risk, yeah.
Increased risk, which is a fairly terrifying statement, because depression is pretty common.
Right.
So my question is, if that depression is appropriately treated during your lifespan before you're 65, do you still fall into that 70% risk group?
I believe your risk with appropriate treatment is augmented, that it's lowered significantly, yes. So that's a very great point, and one to really bring home for individuals who are on the fence about treatment, and that this is something that you can say, hey, long term, it's going to have a significant impact.
Well, let's give Emily a round of applause. I'm sorry we have to call it.
Thank you very much.